For this month clinical meeting. It's going to be from the Department of Surgical Oncology as well as from the Department of Pathology. So the first presentation is going to be from Department of Surgical Oncology, cancer incidence, changing scenario, and how it can be changed. So I was just asking Dr. Bhargavi Madam yesterday or day before yesterday, So the department largely deals with secondary prevention. So I was just thinking the Park textbook on, is it primary to secondary? Now it's primordial prevention. Over to you to see that.
Good morning, everyone gathered here. Myself, Dr. Bhubadi, Surgical Oncology Trainee. I thank our mentors, Dr. Bhargavi Ma'am, Karthikeya Sir and Mohan Raj Sir, and Clinical Committee for giving me an opportunity to present on most important topic of discussion, that is changing incidence in cancer, the changing scenario, and how it can be changed. International Agency on Research on Cancer, the organization of WHO, gives a periodic update on cancer incidence and statistics on a regular updates, where the latest updates was given by Globocon 2022, which is estimates about nearly 2 crore new cases of cancer are getting diagnosed, of which nearly 50% of cancer-related deaths are occurring. The most important leading cancers in the world is ranked by lung at the first place, breast at the second, followed by colorectal. Breast cancer remains to be the number 2 in case of incidence rate following lung, but the mortality rate it ranks around rank 4. We can see that the incidence and mortality and prevalence rate is higher in case of Asian population, which is represented by green, followed by Western countries like Europe with blue. You can see this blue color bar represents the incidence rate and red color bar represents the mortality. The incidence rates of breast are increasing, whereas we have seen in the case of lung, there is disproportionately higher mortality rate, around 17%, when compared with incidence rate of 24%. This is the most important slide where incidence rates between the developing nations and developed countries are compared. On the right side is the low income developing countries like us, and the left side is the higher developed countries. We can see that the incidence rate of breast cancer is increasing both in the developed countries and developing countries. The important point here is to note that though the incidence rate is increasing in both the countries, but proportionally the mortality rate is higher in the developing countries like us. So as per Globocon 22, the statistics given with respect to India, nearly 14 lakh new cases are getting diagnosed, of which 70% of death are occurring related to cancers. In India, the top three leading cancers are breast, followed by lip and oral cavity, and the cancer cervix. And these three are also ranks in the number of deaths caused by this. So nearly 50% of these cancers can be prevented, can be screen detectable. When detected at the early stage, can reduce the mortality occurring to this. This is the statistics which was there 10 years back in 2015, where breast remains to be the primary cause for a majority of cases. In case of males, it was lung earlier, followed by stomach, and then oral cavity. But this incidence is changing. In case of statistics which given by 2019 and which was projected to estimate the number of cases in 2024, the oral cavity has taken the first rank, followed by prostate and the lung. In case of women, the breast remains to be the top, followed by cervix. Previously, it was ovarian disease, ovarian cancer, which was in the third place, but we are seeing more cases of CA endometrium right now. Comparing the incidence rates between the rural and urban population, we have two cancer registries for rural and urban. For rural, we have Dindigul registry, which represents the most cancer cases diagnosed in the rural population. The urban registry is managed by Area Cancer Institute, and it's also governed by the government of Tamil Nadu with the Family and Health Welfare, where the incidence rate of breast cancer is increasing in both rural and urban population, where the incidence rate is about 30 per 1 lakh population in urban, but it's 5 per 1 lakh population rural population, rural individuals. This may be largely attributed to the underdiagnosis of the cancer in rural population and the incomplete registries in the rural population as well. But the incidence of breast cancer in urban population is increasing. It's majorly due to delayed pregnancy, lower breastfeeding, fewer children, and increased obesity. And one advantage is that people are getting access to the advanced screening facilities. These are the 28 population-based cancer registries all over India, where under the National Cancer Registry Program, these registries have the population and cancer incidence between the registries were compared, where Hyderabad ranks first, followed by Chennai and Bangalore in case of breast cancer incidence. This is the population-based registry where Indian registries were compared with non-Asian countries like France, US and Canada, where our population registry ranks one among those in 12, and it's one of the increasing incidence rates in India is noted. In India, nearly for every 4 minutes, a new woman is getting diagnosed with breast cancer. For every 8 minutes, a woman dies of breast cancers. Majority, almost 60% of these cancers are diagnosed at the advanced stage like stage 3 and 4. So screening of these patients is of prime importance. How can we overcome with this increasing in the incidence rates and the death related to this can be overcome by screening. So we have screening for breast cancer, which is primarily by breast self-examinations and clinical breast examination and mammography. Clinical breast examination mammography remains to be the most important clinical tool in diagnosing the cancer breast at the earliest stage and treating them. Majority of the cancer guidelines with the Association of Oncology, Radiologists and Gynecologists recommend screening of the women starting at the age of 40 years, whereas United States Preventive Force Task Force, which suggests mammography to be done every 2 years. The lifetime risk of developing malignancy, breast malignancy in the general population is 12 to 13%, whereas the risk goes up to 60 to 80% in case of any hereditary mutated or gene mutated patient with BRCA carrier. So who are those patients who are at high risk? The patients who have been diagnosed with the family history of BRCA1 and 2 mutations, PALB2 mutation, CHEK2 and ATM, and patients who have been diagnosed at the age less than 50 years, patients who have aggressive histopathology like triple negative breast cancer diagnosed up to 65 years, and patients who have personal history of cancers. So screening of these high-risk population is of prime importance as the gene mutated in these patients have high penetrance, and these patients present at a very earlier age, they present with aggressive histology and aggressive behavior. So screening of these patients is of prime importance. We can see that the screening for these individuals starts at a much earlier age, which is 30. From the 30 years of age, they will be undergoing mammography, whereas in general population, they will be going mammography after 40 years. And highly mutated genes like T53 and BRCA1 and 2, the screening has to be started at the earliest. Like from the age of 18 years, the high-risk woman should be taught about the breast awareness, self-breast examinations. From 25 to 29 years, the patient must undergo annual MRI mammo, where and mammography of X-ray mammography should be done after 30 years, because X-ray mammography also has some disadvantages like it's also a radiation exposure. The radiation exposure and the possibility of picking up a disease in a dense breast at the in younger women is very less. Coming to next most important screening, the screening of cancer cervix, where the recommended is HPV testing and Pap smear testing to be done every 5 years, or Pap test alone done to be every 3 years. Any persistent HPV infection in an individual more than 30 years should be considered significant, and they should be undergoing screening. So cancer cervix screening can be done either with co-testing, that is testing for both HPV DNA as well as with the Pap smear cytology. What is reflexive testing? When we do Pap smear and if it reports to be as abnormality, and then we go for HPV testing, DNA testing, it's called reflexive testing. When to discontinue the screening for cancer cervix? When 3 consecutive Pap smears are reported to be negative in the last 10 years, and at least 1 Pap smear to be done within 5 years. Whether HPV vaccinated individuals have to undergo screening? Yes, they should undergo screening, because HPV vaccines are preventable for only specific strains of viruses. Other strains can also cause dysplasia and cancer cervix. Whether post-hysterectomy patients undergo screening? Yes, they should definitely undergo screening to prevent wall carcinomas. In case of low-income countries, where visual inspection of cervix followed by immediate colposcopy, and if any suspicions or abnormal lesions are seen, they should undergo cryotherapy. So this technique and this strategy is of more importance in case of low-income countries. One of the most overlooked and underdiagnosed cancer is oral cavity malignancy, where screening of oral cancer is of most importance, where a mere 5-minute examination of oral cavity by a trained health professional helps in preventing the cancer and helps in saving a life. This was validated and proved by a randomized control trial which was conducted in Kerala, which was funded by WHO, which shows that it was conducted in 1996. For 3 years, the individuals were exposed to screening by healthcare professionals, and the mortality rate between the screened individuals and non-screened individuals were compared. We show that the mortality rate is much lower in screened population than unscreened population. So we in our Ramakrishna Hospital do screening for these 3 important cancers, that is breast, cervix, and oral cavity, under the project Deepam, where women over 30 years and who are asymptomatic are subjected to screening. The woman will undergo both clinical breast examination and pap-based testing. But this project even was started much earlier in 2005 in August, and still continuing and growing in a bigger size, where we are able to screen more than 5 districts on the western part of Tamil Nadu, and we have screened almost about 3,72,000 females, where malignant cases were diagnosed in 450, and cancer services were diagnosed nearly 250 patients. Along with Ramakrishna Dental Hospital, we are doing oral visual inspection screening, where the healthcare professionals are trained to inspect the oral cavity, and nearly 75 cases of carcinoma are detected. So these are the three cancers for which there is mandatory screening guidelines. Next, we see about the colorectal cancer. It's one of the leading cause for death all over the world, but the colorectal cancer incidence is lower in India. It was 4.4% incidence rate in late 90s, but it has doubled in 2022. It's more common in high income countries, but lower in India. And these patients will undergo only opportunity screening. But high risk patients have to be screened regularly. Who are the high risk patients? Patients with a known history of colorectal cancer, adenomatous polyp, or family history of colorectal cancer polyp, inflammatory bowel disease, who had hereditary syndromes, and who had radiation to pelvis for other malignancies or other conditions. So the patients are the healthy individuals are risk stratified into average and high risk. Average risk individuals should undergo screening at the age of 45 years, and high risk individuals should undergo screening before 45 years. So we have both visual based screening and stool based screening. Stool based screening, the most specific test is fecal immunochemical test, followed by a fecal occult blood test. And for visual inspection screening, we have colonoscopy, virtual coronography, and flexible sigmoidoscopy. The patients who are less than 50 years and no family history do not need any screening, but the patients who are more than 45 years should undergo average screening, that is screening for every 10 years. And patients with a positive family history to undergo screening with colonoscopy every 5 years, or to undergo screening at 10 years earlier than the individuals who are diagnosed with the cancer. So screening for ovarian endometrium, there is no general population based screening. Only high risk screening is for ovarian endometrium. Ovarian cancer syndromes like BRCA1 and 2, HNPCC, that is Lynch syndrome, and SON family history patients should undergo annual vaginal pelvic examination, CA125 annually, and transvaginal ultrasound 6 to 12 months. And patients who have completed family or more than 35 years to undergo prophylactic salpingo-oophorectomy. In case of endometrial cancer with Lynch syndrome, they should undergo annual endometrial biopsy beginning at 35 years. Coming to lung cancer, where annual low-dose CT of chest is the only screening tool available, whereas chest X-ray, the sputum analysis or cytology or biomarkers, they do not form as a screening tool. According to United States Preventive Force, the individuals who are aged more than 50 to 80 years who had quit smoking or currently smoking in the last 15 years and who have a history of 20-year past history should undergo screening for lung. Coming to screening of prostate, screening of prostate is necessary. There are two screening tools, that is serum, PSA, and distal rectal examination. PSA is organ specific, but it can get elevated in non-cancerous and inflammatory conditions. The screening of prostate to be done with a shared decision making with the patient and with the healthcare provider, where 55 to 70 years men will undergo screening. In case of 1,000 screened patients, only 3 die from prostate cancer, and out of 1,000 non-screened individuals, only 4 die from it. This brings to a point whether screening for prostate cancer is nearly necessary. It's a big question. The numbers benefit with the screening only 0.1%, and we can see that the autopsy study of prostate shows prostate cancer in nearly 40 to 50% of the individuals. Coming to the last slide, but important one, how can prevention is better than cure, they say, and how can we prevent the cancer and control the cancer by individual perspective as a healthcare provider and as a community. From our individual perspective, we should be reducing the risk for malignancies like reducing the tobacco usage alcohol, having a healthy dietary factors, engaging ourselves in physical activities, and exposing ourselves to vaccinations about with vaccination preventable viruses and cancer, and uh, early detection of tumor with engaging ourselves in screening facilities and seeking prompt medical advice and complying to the treatment. As a policy and programs, the government has already amended a bill in Parliament, that is Breast Cancer Awareness Bill in 2022, that patients has to be exposed to awareness programs and they should be screened regularly. So take-home message is, though the screening increases the incidence rate, it also increases the picking of the patient at the earliest stage and treating them at the earliest. The severity of the treatment will be minimal and the cure rates will be higher. So women more than 40 years should undergo breast screening, and women over 30 years with present HPV infection should undergo pap smear testing, and oral visual inspection by healthcare providers is of much importance. Thank you.
Lastly, epidemiology talk. Questions, please.
As an MBBS student,
Yes, sir.
I went to Madurai Medical College and saw the pathology department board.
Yes, sir.
Still I remember the incidence of malignancy was highest in carcinoma cervix. It was more than 3,000. Next is ENT.
Yeah, or
It was the order then. Now it has changed. And what about the veterinary medicine? We are dealing with tobacco cases, alcohol. They don't indulge in all those things. Is the incidence of cancer there in veterinary medicine? And do they have made any changes?
Sir, out of box question. Out of syllabus.
I think the lifetime of a human individual is not enough to read and spread awareness about it.
Hello. In the post-hysterectomy patients, we have been asked to do the pap smear screening for the wall only if there is a CAN to CAN3. If there is a purely benign and the pap smear was normal, we are not regularly doing that. That is the recommendations given by our federations. That's one. Second, in what situations you will do BRCA 1 and 2 for regularly for the screen, like very young women and the index patient, and then follow up. If they survive, suppose even very younger age, future fertility suggestions, what is, because right now we are coming across patients conceiving and developing the second primary in the other breast, something like that. So that is second thing. And we do, along with hysterectomy, we do the salpingectomy in all patients wherever we retain the ovaries to reduce the incidence of CA ovaries. That's it. And HPV vaccination, broadly we undertake along with the pediatricians to reduce the CA cervix incidence.
The BRCA patients, I think they form a very small portion of the cancer breast patient. Why we brought up this topic is, last week we operated on a Miss, I should not quote the name, but I do want to tell Miss Shweta, who's 22 years old, diagnosed with LABC post chemo, and we have done a mastectomy because she had an LABC. Just brings it to the point, where are we despite so many screening tools and advancements? As you saw in the projection, the mortality is still over 50%. So all of us have to gear up to find out that somehow we have to, enforce measures. And the other thing is, I want to, yes, yeah. Future fertility is a definite possibility. The only thing what we are worried about is the teratogenicity of the drug if the patient is going to conceive early. The rest of things, we have to keep the patient on constant surveillance, which is of utmost importance, which goes lacking in our population. And they say, 5 வருஷம் நன்னா இருப்பான்னு சொல்லிட்டா. We talk of 5-year survival, 60%, which indicates 100 patients, if we take in that stage of the disease, 60 survive at 5 years. That's what we say. We don't know whether they will be in the 60 or whether they will be in the 40. But patients always go with the misconception, 5 வருஷத்துக்கு disease வராது. So surveillance is of utmost importance in all our patients, whomever we treat, at least an annual if they are past 5 years of treatment. So till then, a 3-monthly follow-up, till 3 years, 6-monthly follow-up, till 5 years, annual follow-up after this thing. The thing is, in BRCA ones, we have to be up and about to make sure that they are on constant surveillance. And one more thing is, there is a maintenance adjuvant drug called olaparib, which is available, which can be taken for 2 years, which is supposed to decrease the incidence of the second primaries in the case of BRCA1s. Even that, we still do not know whether it will reduce the incidence, because BRCA1 mutation itself has a very high penetrance that by 80 years, 85-90% of them will develop breast cancer. But it's not so with ovarian cancer, which happens only in 40 if it is BRCA2 and 60% if it is BRCA1. And the other thing is, I want to allay this thing, a misconception that many patients walk in and ask for PET scan to rule out cancer. PET scan is not the tool for screening. Why? Very high radiation dose. Okay, how often will we repeat it? That will produce second cancers. So,
And see.
yeah?
And see.
Yeah. So the thing is, it is not against modernization. We have to go back to our roots to say, do we make the lifestyle changes which are only healthy? Okay. My appeal to the population here: will we all say we will quit smoking and tobacco in any form and drinking? Okay. I will say then the point is well done. Because we might call ourselves as social drinkers, but we are the ones who are the example of for the public. Okay, tomorrow we walk into a club and we booze. Somebody else walks in. They might be our patient's relative. They find you boozing. They say doctor himself drinks, doctor himself or herself smokes, and so practice before we preach. Maybe we can convey more to the public by being what we are and be an example to the public in prevention of cancer. Thank you.
No, I think two more. Madam, you asked 3 questions, I think. Yeah. So got answered.
Why I asked for that breast cancer patient? She was treated for. She's a survivor. She had an IVF conception after the 11 years of that, and now she's got another breast intraductal. There also it's a breast preserving surgery was done, and complete treatment. She was told she was on a follow-up. Free of the malignancy. So now she's around 33 weeks. Now the biopsy is taken and proven. It's still a lump. It's not deeply penetrated. Whatever it is, she is the very strong family history in the family of different kinds of cancer, all kinds of cancer. Still, people take up the risk. That's what worrying.
So in this patient, madam, we have to wait for the conception to complete till you think, that's what. You think the baby will be viable and then go ahead with the treatment.
As you said, I was told that some safe drugs can be given now, but the patient is hesitating to take the drugs because of the neonatal issues. We have consulted with the neonatals. We will be dealing with the pregnancy and within 3 weeks and then do it off. And BRCA 1 and 2.
Yeah, BRCA 1 and 2, it is for high-risk individuals. As you said, very strong family history of any glandular malignancy. Ovary, endometrium, even pancreas, any GI malignancy. Family history is there. We have to screen for them. And the other thing is age is an important factor. Less than 45 years, we have to look for BRCA gene mutation. And yeah. For the family, yes, all of them have to be screened. If you find the index patient to have BRCA mutation, family has to be screened for BRCA mutation. Men have increased risk for prostatic cancer and pancreatic cancer. So BRCA2 mutations increase risk even in males. BRCA1 mutation definitely ovarian and breast, plus other malignancies. Only thing is we can't live in fear. We can't allow the patients to live in fear. Only thing is we have to put into their minds the necessity for surveillance. Again, after all these things, we have to go back to say, we used to have that this thing of aponym of caution, change in bowel habits, all that to this thing. We have to stay back to that. Any symptom beyond 2 weeks, kindly come to a clinician who has the orientation to detect malignancy. Because many a time we find, why he put those 8 steps is, many a time it's being missed. And the patients come with, ulcer in the upper buccogingival sulcus, and then it turns out to be eroding the alveolus. So the thing is, we have to make sure that every patient whom we see, we have to just tell them this. Any symptom beyond 2 weeks, kindly report to a clinician. And BRCA mutation, we need not make them get feared. We need not, but we have to keep them under constant surveillance, just that. And the other thing is, whenever patient has a conception, we will not want to give any drug, because if at all we'll lose the patient. We can't leave behind a, retarded child. Yeah. So no drugs, no treatment.
Actually, the population screening which we saw for 25 years, we picked up almost 600 patients. We saved them, but so many of them we screened. The screening, I think, especially for the females, the breast, once in a month self-breast examination, what we are preaching, it should go to the school level once in a week or something. At least they follow once in a month. If you say once in a week, from parents to teachers, in that way, I think we can pick up more than any screening task we do. That's one thing which I wanted to just suggest.
The thing is, this breast self-examination pamphlet which he projected, we've been distributing since 2005, when Dr. Kalam came in to inaugurate the program. And every patient who walks in with even a benign breast complaint, they all get the pamphlet. And only thing is, the population is too huge for one hospital to take it up to the school level. Okay, but we do give a lot of, all of us go for giving awareness talk to police training camps, where we mainly say this, and we distribute the pamphlets to this arts college. And that's the bit we are able to do as of now, because the population is so high that, for the clinician to go out to reach completely to the society is becoming difficult.
But in that, please.
No problems.
So, all the age group, if you do the screening for CA breast, if we start screening the children at schools, will be able to pick up a lot of fibroadenomas, and will it lead to a lot of stress to the person later?
No, I want to make other point that way. Lot of children with who are about to go for exam in 10th and 12th standard come with large fibroadenomas.
Yes.
Okay, they are so much stressed that they say, exercise it now. I said 2 months exam is there, you finish it and come. They say, this is a stress on my head. That again brings us to the point, it's all because of lifestyle changes. Because we used to see fibroadenomas when I was doing PG in 96 maybe. They were all, around 25 years or 27 years old, 22 maybe. Now all 15, 16s are getting large fibroadenomas, which will, cause some kind of a little bit of a distortion of the breast at least. And you have to do it scarless and kind of things. So it's all basically lifestyle changes.
I will ask question to Madam. By doing a salpingectomy during hysterectomy, how it reduces the incidence of CA ovary?
The studies have proven that serous tubal intraepithelial cells, cancer cells, spread from the fimbrial end of the tube and then cause malignancy of the ovary. So we prophylactically take out the tubes while doing hysterectomy when we are retaining the ovaries. We are supposed to retain the ovaries till 50 if it is normal, and more so for future support for the health system. That is one thing. That's I think. Second, self-examination of the breast. For all the master health checkup patients, we teach them, we instruct them. We are telling them to do. Most of them had regular master health checkups somewhere or here also. So when we ask them whether you are aware, only 20% are aware. So we make it a point that along with the family members, we teach them the self-examination of the breast, which is very useful, and we tell them about the HPV vaccination even for their children.
Thank you, Madam.
Small point to make, ovaries have to be removed in high-risk patients. There is no doubt about it. Okay. Risk reduction, salpingo-oophorectomy, it's called RRSO. Okay, that is risk reduction. Because wherever you find there is an increased risk of cancer in BRCA patients, you have to do oophorectomy. Why it is not so much talked about than a prophylactic mastectomy is the penetrance is less. And the other thing is the whole of the peritoneum is at risk. Okay, even if you did a oophorectomy, you have to screen for the peritoneum because they have the similar embryological origin.
Good morning, everyone. Only thing, few points I just want to stress. See, often tell my juniors that of all so many lakhs of species on earth, only one species doesn't live in concordance with nature. That is we human beings. That's why we face all these problems. In the name of advancements or civilization or modernization, whatever, unfortunately, knowingly or unknowingly, we have developed so much complicated side effects. There are so many, and most of the thing is, we harp mostly on early detection only. We don't talk about prevention much. That is the sad part of it. And there are so many, for example, I'm just telling, there are so many studies that say air pollution can cause breast cancer, not lung cancer alone. Air pollution can cause diabetes, air pollution can cause sarcoidosis, and air pollution can cause so many pulmonary diseases. So we are not harping on all those things. We are not thinking, we are not paying any attention, we are not done anything to prevent such things. So what I just want to stress is the more we move away from nature, the more number of diseases we get. That's all. Thank you.
Thank you, sir. So before Sedu takes over, so I want to make you have something?
Yeah, I wanted to congratulate the oncology team that they mentioned one point that we being doctors, we when we go to a club, when people see us, see it's a very important thing. So people watch us and they always say that, oh, if they are, so we should also practice etiquette about ourselves, how we maintain ourselves. So that's a very important point which Bhargavi said. Whether we like it or not, we heart of heart know that there is the truth in that. Second point I wanted to tell is, Kartiyesh was telling about nature. I'll tell you something, we struggle to prevent. We are running a race to prevent. But then certain things you cannot prevent. You cannot prevent. But the point is, once you have been diagnosed, before that you could have an attitude as you grow older. How will you see it? But that is something which is a choice which we can do it. So that is number. Because I found out, after so many years, I have found out something that any disease can knock you anytime. But it is the mental state of you when it is hitting you. Now that cannot be spontaneous. It has to be natural, a legacy you should have, an orientation that okay. Now you know that after COVID, do you have any guarantee of life and living? No chance. Patients ask me about the success of surgery. I told my wife that I'm coming for lunch today, will I surely go? I may die in an accident. So the point is, the mental attitude is very important during such things. So prevention we can tell, screening we can do, but again behind all that, I found out a lot of cancer survivors. I've seen them that it is a strong mental attitude with which you go. And I wanted to bring that screening part, including the mental attitude. That is where meditation, yoga, and all this helps you too much. Another one question I want to have to Bhargavi and Kartiyesh is, there is a huge group of this autoimmune diseases. We are seeing a lot of autoimmune, thyroids, rheumatoid. Now, what is the percentage of malignancy in this group? All are undergoing treatment. So we are dealing with something which is a benign, rectifiable, but something which has happened out of control inside. So what is your experience of autoimmune problems and malignancy?
Autoimmune can masquerade a cancer, sir. Generally, it's not an increased risk for cancer. Actually, that's how it is. It doesn't increase the risk, but it can masquerade as you find a lot of mediastinal nodes. It can happen in the lymphoma, it can happen in occult primary of the lung, but it can be just a sarcoid as well. So it masquerades. So it is of utmost importance to make sure that, see, for example, lichen planus of the tongue is often mistaken and treated as lichen planus while it will be a malignancy of the tongue. So it masquerades. So to differentiate is very important so that survival will improve.
Thank you, madam. Thank you. And to put it very shortly, what both of them have told us, even in this group, people are smoking and drinking. Over to you to introduce it, Dr. Sedu.
Thank you. Sedu, why we brought in Sedu is when Dr. Loganathan told the second topic is by the pathology department. I take the excuse of madams from pathology and say, Sedu, not only Sedu, the pathologists are, one of our important, I would not call them as hands because we stand on legs. Okay, they are pillars in oncology because they are the ones who can help us to treat patients. The clinician just delivers, he is the postman. Okay, the letter is written by pathologist. Yes, whatever they write, they are the jury. Okay, whatever they say, we will just execute. So, on to Sedu, the whole pathology department of Ramakrishna has been of utmost, support to us, and we don't think pathology department as a separate department. It is part of oncology.
Thank you for the overwhelming introduction. That makes it more burden on me while reporting the cases. So today's topic is histomorphology and again the role of the pathologist. So it is not just the diagnosis, as you have heard Dr. Bhupati, right from the screening, diagnosis, and then treatment, and then prognostication. Of late, the theranostic implication of pathology. So, to which drug to be, what treatment to be decided, which drug to be chosen, and of even some cases, even the dose of the drugs. So with that, I have chosen certain cases which would be of interest even for the audience. So to know what we do to arrive at a diagnosis and how we go about each cases that we come across. So case number 1 is a young lady who had a swelling for the past 3 or 4 months, and there was a infiltrating mass in the ankle joint, and she went to below knee amputation. The size of the mass was about 14 centimeter. So this was infiltrating the ankle joint completely. So it was an infiltrating malignancy, predominantly of a spindle morphology. So this is predominantly in a fascicular pattern and storiform pattern. Sorry, I have to rush. I cannot explain each pattern because it will be very difficult for everyone to pay attention for a span of 20 to 30 minutes. So it is a high-grade malignancy in a young female. So what would we think in a such age group is our differential will lie on morphology, age, and site, and to an extent to sex of the patient. So in this case, I would think of synovial sarcoma, Ewing sarcoma as the differential. So initial panel, what we choose after morphology, we go ahead with immunohistochemistry. So to subtype what the tumor is. What we have said is a sarcoma is not sufficient enough to treat. We need to subtype what is the type of sarcoma, because for each category of sarcomas, it has to be tailored for chemotherapy and or adjuvant radiotherapy. So initial my differentials were synovial sarcoma, Ewing sarcoma. So initial IHC panel, everything was negative. So what next is in this age group? Is it Ewing's like sarcoma? So we did BCAR. It is a new marker which is present, and I will come about this entity, which is strongly positive. Whatever we are seeing brown is positive. Blue is negative in IHC, and cyclin D1 and SAT-B2, all these markers are negative. TLE1 is a synovial sarcoma marker. It is positive but only weak. So it is a new entity called sarcoma with BCAR rearrangement or BCAR G alteration. So the undifferentiated round cell sarcomas are classified as now recently Ewing, round cell sarcoma with EWSR1 non-ETS fusion, CIC rearrangement sarcoma, and sarcoma with BCAR rearrangement. Earlier it was only Ewing and Ewing-like sarcoma. Now, based on the genetic alteration, they have subdivided these Ewing sarcomas as, other than Ewing, we have specific molecular signature for these sarcomas. Therapy-wise, they are more or less same at this point of time. They all undergo Ewing's chemotherapy regimen. So what is it? It is a primitive, BCAR sarcoma is a primitive round cell sarcoma, and it could be either overexpression or it is due to tandem duplication. So most of these BCAR sarcomas are seen in young patients, mostly in boys, and they occur more often in the bone than soft tissue. So similarly, we had a young female with loin pain, and she was found to have on workup, she was found to have a renal mass. She underwent nephrectomy, and again a spindle cell sarcoma in a young female. These will be the differentials. Young female, renal mass, whether it is a synovial sarcoma or is a rhabdomyosarcoma of spindle cell type, or it is a leiomyosarcoma. So again, the initial workup, TLE1 is a synovial sarcoma marker, CD99 synovial sarcoma, usually it will be positive, BCL2 positive, CD56 positive, and NKX2.2 is a Ewing sarcoma marker. It is weak and focally positive. You would expect a strong diffuse positivity, but in this case it is only weak. So other markers run were all negative. So is it a synovial sarcoma occurring in kidney? It is known synovial sarcoma can occur in not only in somatic soft tissues, also in visceral organs it can occur. But in kidney, how often do we find it? In spite of having a strong TLE1 expression and other markers positivity for synovial sarcoma, but it was little, I was little apprehensive whether at this age is it how common it is. So what next? How do we confirm it whether it is synovial sarcoma? We need to go for molecular testing. SS18, SSX. It's a molecular signature specific for synovial sarcoma, and it came out as negative. So we are wrong in thinking it as synovial sarcoma. So what it is next? Whether it is a Ewing sarcoma, again EWSR1 FLY1 molecular testing was done. It is negative. But again, what will have a similar morphology? Expressing in the previous case, we had seen TLE1 expression. So we thought whether it could be a Beaker mutated sarcoma. So again, Beaker was positive in this case. Cyclin D1 again a Beaker sarcoma related marker. So it is a clear cell sarcoma of kidney or a Beaker or sarcoma with Beaker genetic alteration. Usually clear cell sarcoma is a pediatric age group sarcoma. Usually we get to see 1 to 5 year of age group. But this is there are case reports have been reported in young adults with clear cell sarcoma. So now the patient had delivered twice and she is doing well. Again, going to next case, it's a young female with a pelvic mass and pleural effusion and ascites. So she underwent oophorectomy. There is a huge cystic mass, predominantly solid and focal patchy solid areas, giving a honeycomb appearance. So this is the morphology. We have predominantly bluish solid epithelial-like areas. So hyper, we can see the tubule round structures. These are all Sertoli cells. What we are seeing is, which looks like an adenocarcinoma, gland-like structures, but these rounded structures are Sertoli cells. They can be seen in cords or closed lumen, retiform pattern, and these high-grade areas, undifferentiated. What we are seeing is tubular round structures, and some areas are solid. So these are primitive areas, undifferentiated primitive areas. You can see they appear round to spindle shape. So we call it as a primitive undifferentiated malignant component. So we are seeing a differentiated component and we are seeing an undifferentiated component. So these are Leydig cells. So now the diagnosis is we have Sertoli cell and Leydig cell. The diagnosis is Sertoli Leydig cell tumor. It is a sex cord stromal tumor of ovary. So the diagnosis is Sertoli Leydig cell tumor, and the grade is very important. Why the grade is important is because of the designation, whether we are going to call it as a benign or malignant. If it is low grade, well differentiated, it is going to be a benign. No adjuvant treatment is required. When it is only primitive component, what I showed, the sheets of areas, it is poorly differentiated, Sertoli Leydig. So this needs adjuvant therapy. Anything in between is moderately differentiated. Our case had both well differentiated and poorly differentiated areas. So it's a moderately differentiated. So it's a borderline category of sex cord stromal tumor. They constitute only less than 0.5% of all ovarian neoplasms. The age group is broad, and most of the cases are virilized. Our patient had features of virilization. So going to next case, it's a 43-year-old female, low abdominal pain, and on ultrasound she was found to have a vascular neoplastic lesion arising from the vagina. So a subsequent pelvis was MRI pelvis was done, again showing it to be a vascular neoplasm, and it was excised. So a solid tumor, large cells appearing in vagueness, and you can see these are all blood vessels, highly vascular. So probably that is why the ultrasound and MRI showed it as a highly vascular tumor, and while removing there is a profuse bleeding. So highly clear cells, large cells, in cervix, the common things are common. So what we want to think is squamous cell carcinoma, more commonly, or an adenocarcinoma polydifferentiated type. So IHC was done to know, because morphologically I'm sure that this is not a squamous cell, but we need to exclude what we are thinking it is not. We need to prove. So P40 is a squamous cell marker. It's negative completely. Pancytokeratin negative. So it is not an epithelial tumor. So what we are dealing, it is not an epithelial tumor, it is some other tumor. Is it a hematolymphoid? No, morphologically. So it is a mesenchymal, let us see. So what common mesenchymal tumors which we come across is melanomas of female genital tract, leiomyosarcomas, and other mesenchymal tumors. Ascended is a melanoma marker negative. Melanie again melanoma marker negative. So HMB45 is strongly positive. Why 3 markers? When we suspect something, we cannot just do 1 marker and go away. We need to have at least, most of the situation I'm saying, at least 2 markers to prove this is not what we are thinking it as. But HMB45 is the only melanocytic marker, it is positive. But the common markers for melanoma are S100 and melan A, which are negative. So what it is now? Desmin is positive. It's a muscle marker. So now we have a tumor which expressing melanoma marker and a muscle marker. So among the muscle we have desmin and HCAL-desmin positive, SMA negative. So I'll come to TFE3. So it is a PCOMA, perivascular epithelioid cell tumor. Again, site-wise it is common. More often we come across in kidney, rarely in sites like lung. But in female genital tract, it is very uncommon. So it is the morphology, what you are thinking, and subsequent IHC you plan in the differentials what you want to exclude or include. So it is a PCOMA. It's a very rare entity. It is a benign tumor. There was no worrisome features of malignancy in it. Rare tumors can have malignant features, but this does not have. TFE3 is a subtype of PCOMA. Prognosis wise, there's nothing, no change, but it's just of academic interest. That's all. So next case, it's a 66-year-old male had a right mastoid swelling and pain. This case was referred from outside. He had only swelling and pain in the mastoid region, so we did not have much details about the patient. So only the initial finding what I had was a CT scan showing a small mass of 4 centimeter. The slides reviewed showed mostly a mesenchymal tumor. This is a bone. What you are seeing is a bone, probably a mastoid bone or surrounding parietal or occipital bone. And this is spindle cell tumor, purely spindle cell, but no significant ATP. They appear monomorphic, bland appearing spindle cell, and rich in vascularity. You can see thick blood vessels. Thick blood vessels at high part. This is a blood vessel surrounding spindle cells. So some places has adipocytic component. These clear spaces are all adipocytes. So at one focus I found a cartilage. So again we need to think, putting up all together, we are dealing with a mesenchymal tumor with having 3 different, all only mesenchymal, for the different spindle cell, adipocytic and focal cartilage. Definitely this cartilage is a benign cartilage, not a malignant cartilage. So it is very less likely to be a sarcoma. So what tumor can it be? So we had a lot of differentials in it. So most of the markers are negative. So only one marker, it's a SAD-B2 which is strongly positive and CD19 non-specific. So it is a phosphaturic mesenchymal tumor. So this is a very rare tumor, less than 0.1% of all mesenchymal tumors. And morphologically, these tumors, they secrete FGF23, which is a phosphaturic hormone, which goes and inhibits proximal tubule of kidney to prevent reuptake of phosphate. So there will be phosphaturia, loss of phosphate. So eventually the patient will have osteomalacia. So it is most of the cases are benign, very rarely transform into malignancy. And after complete excision, there will be dramatic improvement in the phosphate wasting and thereby improvement in osteomalacia. And subsequently, while inquiring, the patient had history of weakness and tendency for easy fracture. The patient had multiple episodes of fracture, and subsequently they did a DOTA PET. There was this lesion with high uptake, and there were multiple fractures in the ribs and iliac bones, and with the evidence of osteomalacia. So This is a case where because of secretory phosphaturic hormone, the patient had symptoms of osteomalacia and subsequent multiple fractures. So I don't know the follow-up, how is he doing now, because this was worked up outside. So next case, 44-year-old female with breast lump. So it's a true cut biopsy. It's a solid, no tubule formation, solid. So anything in lung, this I would call it as a neuroendocrine carcinoma. High power, very small round cells, nuclear molding, high mitotic activity, small round cells, some vague acinia there. So chromogranin and synaptophysin are all neuroendocrine markers. So they are all diffusely positive. So it's a neuroendocrine carcinoma of breast, small cell type. So how often do we come across neuroendocrine tumors? It's very rare, and maybe one or less than even 1% of breast carcinomas are neuroendocrine. And usually these tumors are hormone positive. In this case, we had ER and PR positive and HER2 equivocal. I think we did HER2 dish subsequently, and it was negative, and Ki67 was high. And another case, 46-year-old female, initial work was done also, post mastectomy. We had a similar tumor, but with less atypia. Similar morphology, but with less atypia, hardly any mitosis, similar nested pattern, typical of neuroendocrine. But this is well differentiated neuroendocrine tumor of breast. Earlier, what we saw was a neuroendocrine carcinoma, but this is a neuroendocrine tumor of low grade. So initially, neuroendocrine tumors was initially in breast. They were described in as early as 1963. Mucinous carcinomas were found to have neuroendocrine differentiation. Later in 1977, they had reported series of cases with carcinoid of breast. And in 2003, WHO recognized neuroendocrine tumors as a distinct entity. But later in 2014, they had given a classification similar to GI tract and lung neuroendocrine, well differentiated and high grade neuroendocrine carcinomas. And the recent consensus is neuroendocrine tumors of breast are well recognized, and they are with they should be predominantly with neuroendocrine differentiation. And morphology and IHC should be concordant. There should not be a focal expression of neuroendocrine markers. It should be both morphology also, it should be neuroendocrine, and as well as the IHC also, it should be supporting the diagnosis of neuroendocrine. So in recent, it is either broadly divided into two, well differentiated neuroendocrine tumors, again subdivided into grade 1 and 2 based upon the usual grading features of CA breast, mitotic activity, tubule and pleomorphism. And the next category is neuroendocrine carcinoma, small and large cell type. So they constitute less than 1% of breast carcinomas. It's both morphology and IHC, they should be concordant. And more important is, because of the rarity, one should exclude metastasis from sites like lung and GI tract. So IHC is a must to exclude metastasis from elsewhere. So next case, 39-year-old male with generalized lymphadenopathy. He had uptake in multiple lymph nodes, both above and below diaphragm. And he had multiple bone lytic lesion with high uptake. So excision biopsy of the cervical node was done. This is of a lymph node with effaced architecture. So we can see round large cells infiltrating, large round cells with sheets and sheets, no any pattern, infiltrating the lymph node. So the common differentials would be a high grade non-Hodgkin lymphoma. So whether it is a DLBC or ALCL, where the differential. So initial we would start with the B cell marker CD20 and T cell marker CD3. All were negative. The brown what you are seeing is all normal reactive population in the lymph node. The most of the large cells in the lymph node, the majority are all negative. So, but CD45 is positive. What we are dealing is a hematolymphoid malignancy with CD20 B cell and T cell marker negative. So, as I told, to disprove that it is not a T or T, we need to add more markers. So, CD2, 4, 5 are all T cell markers. They are all completely negative. Again, B cell marker PAX5 is negative. So, other malignancies in a lymph node like histiocytic tumors or dendritic cell tumors, so one need to exclude. So, all were negative. So, CD117. It is a precursor myeloid marker. It is positive in a lymph node, CD117. CD34, we all know, we will be doing routinely for our stem cell transplant. It is a immature blast marker, CD34 positive. So, yeah, blast marker with myeloid phenotype. So, what it is a acute myeloid leukemia. MP was negative. So subsequently we asked for PS and bone marrow. What we are seeing is full of blasts in peripheral smear. So this is a flow cytometry. Just like IHC, we do flow cytometry to categorize what type of blast it is. This showed again a myeloid phenotype. So it is a myeloid sarcoma presenting as a lymphadenopathy, generalized lymphadenopathy. So any tumor mass involving anatomical site other than marrow, mass formative lesion by proliferation of myeloblasts is called as myeloid sarcoma. So it is seen as high as 9% of patients with AML and post stem cell transplant up to 12%. So it can be detected concurrently or as a relapse in a case of treated case of AML. Next case, 74-year-old female complains of cough with mucoid sputum, and she had shortness of breath and chest tightness. And there is a large pleural-based mass abutting and infiltrating lot of thoracic structures, and there is a mediastinal shift. So TrueCut was done from the mass, and we can see it's a spindle cell neoplasm and very bland appearing spindle cells. As compared to the previous case, the cellularity is very sparse. Pleomorphism is very mild. So in a thoracic based tumor, one would think of differentials like solitary fibrous tumor, inflammatory myofibroblastic tumor, and whether it is a low-grade sarcomatoid mesothelioma. This was the differential, and IHC was planned to exclude or rule in these tumors, except for CD3 and focal desmin. All the markers were negative. So CD34, is it SFT, solitary fibrous tumor? But STAT6 is negative. STAT6 is a very specific marker for solitary fibrous tumor. So it is not solitary fibrous tumor. And desmin, it's focally positive, and other muscle markers are negative. Mesothelial markers, except for focal WT1, all are negative. Neural markers negative. So are we dealing with a gist arising from upper GI tract? So CD117 is negative. So what are we left with? Some rare tumor which has de-differentiated. So CDK4 and the MDM2, that is positive in the tumor cells. It is nothing but a marker specific for liposarcoma. So what we are seeing is a de-differentiated part of liposarcoma which has been biopsied. So the biopsied portion does not show a liposarcoma. Whatever it is showing, it is only spindle cell component. It is a de-differentiated part of liposarcoma. So it's a similar case. Pararenal space, TrueCut, similar morphology, low grade appearing, but ATP was slightly high. This pararenal mass was excised. So what we are seeing is a fatty mass, completely yellowish. And focally we are seeing a nodule with myxoid. You can see a glistening appearance, especially as compared to the adjacent fat. It is pale yellow or pale white with glistening appearance. We call it as myxoid change. Again in a hyper, yellowish and these grey-white areas with myxoid change. So this is a liposarcoma. You can see this adipocyte and this adipocyte. The significant difference in the size. This is very important between a lipoma and liposarcoma. And this is a lipoblast. This is a normal lipocyte and this is a lipoblast. So it is a very characteristic of a liposarcoma. And what we are seeing here is the liposarcoma component, and this is a spindle cell component. Two areas in one field. You can see liposarcoma and this is a spindle cell component. So liposarcoma has de-differentiated. So what we saw in TrueCut is only the de-differentiated part. Most often in the TrueCut, especially from the retroperitoneum or other side, we get to see only the de-differentiated part. So it is very difficult to diagnose because they will have all non-specific markers, CD34, desmin. So high index of suspicion is very important. You can see high pleomorphism, high sarcomatous giant cell, high pleomorphism. So again repeated, MDM2 was repeated. So it is very specific molecular signature. It's a surrogate marker for MDM2 amplification. So it's coming to a pediatric case, 18 days old male baby. So antenatal screenings did not pick up any abnormality. But surprisingly, the child had abdominal distension, and further evaluation found to have a large mass in the retroperitoneum. So initial diagnosis was a neuroblastoma, query neuroblastoma, and TrueCut was done. And this round cell, small appearing round cell, but it had a hepatoid appearance, immature hepatoid appearance. So again, sinusoid like normal liver, what we see, sinusoids. Similar to a normal liver, we had a hepatoid pattern. And this is a erythroid, collection of erythroid. This is extramedullary hematopoiesis. Extramedullary hematopoiesis in a malignancy. So we did a couple of markers. Cytokeratin is strongly positive. Pediatric age group, cytokeratin is an epithelial marker. So what we see, strong diffuse positivity in a carcinoma. So it is a pediatric age group. Our differentials would be neuroblastoma, nephroblastoma, and other DDs. We had heparon, hepatocyte marker. It is positive in the tumor. Lipicantry, again a HCC marker, it is positive. Beta-catenin, it is positive in hepatoblastoma, strongly nuclear and cytoplasmic, both positive. So other DDs, to exclude other DDs in our list, we had done other markers, it's all negative. So it is a hepatoblastoma, well differentiated subtype, fetal type, and subsequently AFP was done. It was sky high, 51,700. So this is the classification: epithelial type and mixed mesenchymal and epithelial type. Again, what are the significances of the prognosis? Again, pediatric age group, 13-year-old male with abdominal distension and pain. There is a large exophytic mass arising from the liver, and you can see solid cystic mass giving like a honeycomb-like appearance. You can see a cystic space like this, and post of HP also cystic spaces like this. Corresponding, these cystic spaces are bile duct, dilated bile ducts. Surrounded by, you can see malignant, high-grade malignancy. You can see stellate, star-like shaped cells and high-grade spindle-shaped cells, and you can see a giant cell, tumor giant cell. So it's an embryonal sarcoma of liver. It's a very rare malignancy occurring in children 5 to 15 years of age. And there is no specific immunophenotype for this. It is solely based on the morphology. It is very aggressive. Most of the time it presents with lung or peritoneal metastasis. And surgically amenable for resection tumors, they do better when it is R0 resection. So next case, it's a 19-year-old male. Limb pain, he had multiple lymphadenopathy and skeletal lesions. So clinically it was a very acute leukemia. So bone marrow was done. They appear like plasma cells. Anything with eccentric nuclei, blue cytoplasm, we would think it as a plasma cell. But it's a young male, lytic lesion, bone with lymphadenopathy. Plasma cell myeloma is very unlikely because it's a disease of late adulthood. So, whether are we dealing with a plasmablastic lymphoma? Plasmablastic lymphoma can occur in a younger age group. So, most of the cells appeared plasmablastic. This is a bone marrow sample. So, these were the DDs I had: plasmablastic lymphoma, DLBCL, ALK positive, and other tumors. And of course, acute leukemia needs to be excluded. Flow cytometry. This is the blast population. What we saw, it is completely negative. It is completely negative for CD45. CD45 is a common lymphocyte antigen marker, and it is negative for all myeloid B cell, T cell. So it's a null phenotype. So what we are dealing is an undifferentiated malignancy. I'm not sure what we are dealing with. So because none of the markers in flow helped us, so we were waiting for the tryphin biopsy to come in, because after a decalcification process, it takes 2 days to 3 days to come in. So we saw this is a bone marrow, bony structures infiltrated by tumor. You can see again similar plasma, cytoid cells, sheets. So not sure what it is. And the patient had again multiple, as I told, multiple lytic lesion. There is a lesion in the rib, PET of FDG lesion, and it was sampled. Again similar morphology, plasma cytoid. And focally there were brown pigment. You can see the focal brown pigment. So it is a melanin-like appearing pigment. So again different areas, melanin-like pigment. So SN was positive. As I told in the previous case, SN, SOX10 again, HMB45 and melanin, they are all melanoma markers. So PAN-CK negative, 45 negative. So it is a metastatic melanoma, or rarely a soft tissue sarcoma called clear cell sarcoma. So the primary is unknown. In this case, the primary is not detected. Maybe in the follow-up we would pick up somewhere in the limb or somewhere occult primary. So next case is 60-year-old female, bleeding PV, and this was evaluated outside and found to be a undifferentiated malignancy. Again a similar tumor. You can see the brown pigment, large cells, brown pigment. So it is a melanoma of cervix, melanoma HMB45 S100 positive. So it's a very rare site. Morphology is easy to pick up, but the site is rare, that's all. So then next case, it's a abdominopelvic mass in a young female, a pedunculated mass arising from the lateral wall of the uterus. So when the abdomen was open, there was a large nodular areas in the omentum. So it was found to be whether it is a deposits, tumor deposits in the omentum. So it was sent for frozen section. And very fleshy appearing tissue. This was received for frozen section. Fleshy appearing tissue. Looked like having a suspicious for malignancy. I thought, okay, could be a malignant tissue. And this is after fixation. You can see the omentum lying down, and this is the tissue after fixation. And now this is less scary as compared to the fresh appearing tissue. A lot of cystic spaces, cystic areas, cystic area, cystic sponge-like appearance. So post of HP, cyst-like areas, and this is a lymph node. What we saw is the tissue is a lymph node with cystically dilated. These are all vascular lymphatic channels within the lymph node. So you can see cystic with proteinous lymph within the cystic area. So it is a multilocular cystic lymphangioma. So here frozen section in this particular case has helped us to not to overdo the surgery, limit the surgery. We had called it as it is just a reactive process. And though we couldn't say what it is specifically, we said it is it doesn't look malignant. So it is very crucial to decide what the lesion is. So in the last case, 66-year-old female, the patient initially had a diagnosis of DCAS. She underwent mastectomy, and within 2 years she developed supraclavicular lymphadenopathy. So again, true cut biopsy was done. It is a metastatic adenocarcinoma. Now what comes, the next question is, have we missed a diagnosis of invasive carcinoma? Because the patient was not on any adjuvant therapy. So have we misdiagnosed invasive component? So anyone would be scared, have we missed out? So we had taken out the specimen and reviewed both the, of course, breast was not there, we had discarded. All the blogs and slides were re-reviewed. It was only DCAS. And then we had compared with PET or mammogram whether there were any other lesion which was undersampled in gross. There were no other lesions. So we're thinking what it could be, whether it is an acral primary of breast and what. And it's a morphology which is a adenocarcinoma. CK7 was positive, 20 negative. GCDFP, mammoglobin, GATA3, they are all breast markers. They are all completely negative. And ERPR HER2 was negative. So we are not dealing with a case of CA breast, especially in a well-differentiated tumor. Undifferentiated or poorly differentiated breast carcinomas can have all these markers negative. But in most of the cases with well-differentiated grade 1, 2 tumors, we expect these markers, at least one of them to be positive, completely being negative. So there must be some other primary. So what next? The patient had symptoms of related to chest symptoms. So we did whether it is a lung, no. So whether it is a mesothelioma, we did calretinin, strongly positive. CK56 again squamous or mesothelial marker positive. Podoplanin strongly positive. WT1 somehow negative in this case. So it is a metastatic mesothelioma, epithelioid type. Usually mesothelioma is a biphasic tumor, epithelioid component and sarcomatoid. So this case what we sampled in the node had only epithelial component mimicking the adenocarcinoma. So PET, we correlated with PET, so we can see the typical, we call it as a ring-like lesion. This is the pleura with high uptake. So it is a metastatic mesothelioma, young female. So the significance is not just only the morphology. We have to think, especially when something is not fitting, you have to think what else it could be. You need to correlate with the clinical findings, and of course whatever evidence or investigations you have available with you, one need to correlate, and wherever it is needed, one need to go for other investigations. It could be a special immunohistochemistry stain, or it could be IHC stain, or molecular markers. So it is very essential to give a complete diagnosis. One need to work up thoroughly. And I thank Shreya team for the opportunity, and your patience for listening. Any questions? I will be happy to answer.
Thank you, Sedu. So largely, Professor will talk on mesenchymal tumors. So tumor of egg stage. That's a wonderful job. Keep doing the good work.
Thank you.
God bless you. I learned that new word, de-differentiated. So, well differentiated, poorly differentiated, moderately. What is this de-differentiated? Does it fit into other three or?
It is going in for undifferentiated grade, sir. Undifferentiated grade or to other lineage. An epithelial component going in for sarcoma.
Okay.
That is de-differentiation. It has every tumor has a lineage: epithelial, mesenchymal, hematolymphoid, germ cell, like that. So if it is going from one lineage to other lineage, we call it as de-differentiated. Or within the same lineage, it goes for the undifferentiated end of the spectrum. So that is called de-differentiation. Whether it is either it is in the same lineage undifferentiated, we call it as de-differentiation, or due to other lineage, carcinoma to sarcoma. In a thyroid, for an example, we have follicular carcinoma or papillary thyroid carcinoma. These are all well differentiated tumors. The other end, we have an anaplastic carcinoma. So it is carcinoma, but it is undifferentiated.
That can be called de-differentiated?
It is de-differentiated. Yeah. It is de-differentiated, sir, but we have more specific terminology, anaplastic. So in a uterus, we call de-differentiated sarcoma, well differentiated to a sarcomatous component. So we call it as a de-differentiated carcinoma, or we have a carcinosarcoma.
Thank you. So we'll take something. Last question.
Differentiated and de-differentiated, what is the difference?
It is only the grade, ma'am. It is undifferentiated. Higher end of the differentiation is poorly differentiated, and de-differentiation is to either undifferentiated in the same lineage or to an other lineage.
So actually there are two varieties, poorly differentiated as well as de-differentiated. Even in the well differentiated, you will sometimes poorly differentiated variants of a follicular disease. Okay,
But
differentiated is extremely good.
But clinically, the poorly differentiated means the worst form. The de-differentiated need not be. Am I right?
No, sir. De-differentiation is much aggressive because we have an undifferentiated component.
But you,
That is what the thing is, it can have sarcomatic element, might be an epithelial tumor, but it will have sarcomatic.
In a thyroid, sir, we have a well differentiated. Say it is a papillary carcinoma, papillary thyroid carcinoma.
no, my understanding was the de-differentiation one. It can pass from this stage to other stage or different spectrum.
It could be either same lineage. It could be either same lineage or to another lineage. That is why I am telling about thyroid carcinoma. We can have a papillary thyroid carcinoma. 95% of the areas are all well differentiated papillary carcinoma morphology. If you have even a 1% of undifferentiated, we call it as anaplastic carcinoma.
Yeah.
So it is a de-differentiation. So the grade now the answer for your question is, sir, it is behavior will be much aggressive. We have thyroid poorly differentiated thyroid carcinomas, but anaplastic is much worse than poorly differentiated. And if we give a diagnosis of anaplastic, they would not operate. They would be hesitant to touch the patient. But for a poorly differentiated, yes, surgery still remain the choice of management.
Is it that only in the well-differentiated group you have de-differentiated? Because often we find this de-differentiated liposarcoma. Because liposarcomas generally, they will be that well-differentiated group type. Or the same chondrosarcomas, they will be, slow-growing, well-differentiated group is fine. So is it only in them that you have de-differentiated?
Most of the de-differentiated carcinoma malignancies, the component would be the milder component would be a well-differentiated grade most of the times.
So that's what happens.
So
The
these
good varieties
words they
become
used to
the
bombard
best.
with the histopathology conference.
Say in uterus, in a de-differentiated carcinoma, the most of the times the carcinoma component is well differentiated. Whereas in a carcinosarcoma, the carcinoma component is of high grade. Carcinosarcoma, the most common carcinoma component is mostly serous carcinoma, mostly. Whereas in a de-differentiated carcinoma of endometrium, most of the times the component of carcinoma is not serous. it will be endometrioid and well differentiated most of the time. Very rarely there could be high grade, but most of the times it will be a low grade.
Thank you, Sedu. So,
See, this on the lighter side. Whether it is differentiated, poorly differentiated, or de-differentiated, anything, it doesn't matter. There is no difference for the, as far as the patient is concerned.
But
No,
for
sir, it
certain
is not
organs,
so. It is not so. See, what's happening now is the treatment is becoming more and more aggressive. All the same, we have to draw a line where we have to limit it. See, we have extensive treatment modes available, and resection is extensive, all that.
No, the comment is not, comment is, that is not matter for the patient.
No, that's what I'm saying. See, poorly differentiated have to be given treatment sometimes. Okay, while de-differentiated, we will have to sit tight. So it makes a difference. Poorly differentiated is not equivalent to de-differentiated regarding treatment.
Okay, so these are the discussions comes after the surgical assessment discussion in tumor boards. Thank you, Dr. Sedu, for a wonderful presentation.